Hello, I'm Mallory Shansfeld, Managing Editor of Endodontic Practice US, a Medmark publication. Welcome to an educational presentation and question and answer with Dr. Chafic Safi. In our webinar today, we will be discussing three components of the endodontic triad: instrumentation, irrigation, and obturation of the root canal anatomy, while allowing clinicians to reach microbial control in a minimally invasive, safe, and efficient manner, streamlining endodontic procedures. Before we get started, I'd like to invite viewers to use the question and answer box to ask any questions, and they'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker. Dr. Chafic Safi completed his postgraduate residency in endodontics at the University of Pennsylvania in 2015, where he also completed a Master of Science in Oral Biology, researching the outcome of endodontic microsurgery and factors affecting prognosis. Dr. Safi is a published researcher and lectures on various endodontic topics, and he's certified by the American Board of Endodontics. Dr. Safi remains on the faculty at the University of Pennsylvania's Department of Endodontics, as well as the University of Montreal as an adjunct professor. He is also a faculty lecturer for the Next Level Endodontics. He founded Centre Endodontic Saint Laurent in Montreal, Canada, where he lives and practices since 2016. Thank you so much for joining us, Dr. Safi. We now turn the webinar over to you to learn more about today's topic.
Thank you, Mally. Thank you for this introduction. Hello, everybody, and welcome to this webinar sponsored by Brasler and housed by Endodontic Practice US, whereby we're going to be talking about anatomically centered endodontics. I remember when I was back a resident at UPenn in Endo, and being in the resident room, we were exposed to this case by our program director back then, Dr. Karabuchak, and he showed us this preoperative radiograph showing us we have a central incisor here with a periapical radiolucency, and that the root canal treatment has been done. This is the postoperative X-ray, as we can see here. And one can say that this root canal has been fairly well executed. We can clearly see the quality of the obturation, a nice lateral or accessory canal that was obtained. And one would expect healing to happen, seeing that, the root canal has been well executed. However, a 12-month follow-up radiograph showed that, contrary to what we would have expected, we still have persistence of the periapical radiolucency and persistence of this disease. And thus, this has pushed me to kind of understand what it takes in order to reach success when doing endodontic treatment, especially when you're doing just regular endodontic treatment and not only, let's say, retreatment. And so to understand success, one has to understand that we are fighting a disease in endodontics. And our disease in endodontics is apical periodontitis, which is illustrated in X-rays by this radiolucency that happens on the apical part of the tooth or sometimes laterally. And we need to either prevent or to treat it. When we see that it's happening, we need to prevent it. And if it's established, we have an establishment of the disease on the X-ray, we need to treat it. In order to treat or to prevent apical periodontitis, we need to control the microbes that are, let's say, either invading the root canal space or already invaded the root canal space. But however, we need also to preserve dentin because we need to save the tooth, right? Pulling the tooth could also lead to microbial control, but we want to conserve the tooth. So microbial control while preserving dentin is how we're going to fight the disease and reach success. And these two items together is what I call anatomical microbial control, hence the title of this presentation, which is Anatomically Centered Endodontics. Now, the treatment to control this disease is a root canal treatment or an endodontic treatment, which involves instrumentation, irrigation, and obturation. This is our famous endodontic triad. And if we do this in a certain protocol, one can expect healing to happen and the periapical tissues to be restored and to be rebuilt and to have really, if you want, the success of the treatment. However, as you might know, and as you might expect, we encounter a lot of challenges as clinicians reaching anatomical microbial control. The first challenge is the anatomy of the root canal treatment, of the root canal system, pardon me, and this has been studied and illustrated and investigated in 1925 by Walter S. in his work where we see that the root canal anatomy is very complex, it's very intricate, it's very, it's not simple at all. We have anastomoses, lateral canal connections, isthmuses, fins, and most of all, we don't have a straight, conical, or round-shaped canal, but we have a really irregular or oval-shaped root canal system in most of the cases. And this translates to the fact that with our common techniques of cleaning this root canal space, we end up leaving behind a lot of untouched surfaces or surfaces that has not been cleaned at all, which could sometimes be up to 80% as we see in this study here. And so our first fact deriving from this study or from this from the challenges that we're encountering is that current instrumentation techniques are deficient. In other words, we are trying to instrument or to clean a non-round canal using materials or using instruments that have a round cross-section. And so this leads to areas that have not been cleaned at all, as we see by these green arrows, and compacting the debris in these non-instrumented areas. And even it leads to non-sealed or non-obturated areas, which of course with time can lead to microbial reinfiltration and thus the persistence or the reoccurrence of the disease. The second challenge that we encounter comes from how the bacteria organize themselves inside the root canal system. We know that bacteria don't just swim alone in the root canal system, but they organize themselves into biofilm. And biofilm is a very tightly organized structure where bacteria hold their hands together in order to bind and to adhere to the dentinal surface and form a substance that's very hard to remove. And so we need to not only clean anatomically, but we also need to be able to scrape and to disorganize this biofilm. And we also need to be able to, if you want, send some fluid or send some microbial action into the dentinal tubuli, because we know that bacteria can travel into the dentinal tubuli up to depth of 375 microns. And if we leave these microbes there in a non-controlled fashion, this could lead to endodontic failure, or if you want, the reinfiltration or recontamination of the root canal system. The third challenge, or the third fact that I want to share with you today, is that our teeth are weakened by our current or conventional endodontic instrumentation. And this comes from the fact that a lot of studies have been done in order to see what are the causes of endodontically treated teeth that have been extracted. And this study has looked at 547 extractions of endodontically treated teeth, and about 9% of these teeth have been extracted due to fracture. Of course, there are other reasons such as period disease, coronal fracture, trauma, caries, etc. But 9% of the time, when a root canal treated tooth has been extracted, it's due to a fracture or to a cracked tooth. And this is what it looks like. If you want clinically, we have here at the distal part of this mandibular molar, a crack running from the distal marginal ridge all the way down to the root canal system. And this has been, if you want, investigated and studied. And today we know that because of all the torque and all the stress that is implied on the tooth with our conventional root canal instruments, especially the ones with greater taper, we are grinding more dentin and thus weakening the tooth or thinning the dentin and leading to cracks eventually and the loss of the tooth. The fourth challenge, or the fourth fact that I would like to share with you today, is that our current irrigation techniques are also deficient, namely because we have the formation of a bubble at the apical part of any root canal system that we are treating, and this gas bubble, also called vapor lock, doesn't let us, if you want, to reach microbial control all the way to the apical part, and thus leaves behind bacteria and biofilm, which can eventually cause the persistence or the recurrence or the failure of our root canal treatment. And finally, if this wasn't enough, when I was looking into why this simple central incisor case has failed as I was a resident, I found also literature showing me that traditional root canal sealers, which might have been used in the case that I shared with you at the beginning, also fall short of ideal, meaning that our traditional sealers made of, let's say, based on calcium hydroxide or resin or epoxy, they tend to shrink with time, they tend to wash away, they don't have any interaction with the dentin, so there's no bond eventually everything leading to microbial leakage and the recurrence or the persistence of the periapical disease or of our endodontic disease. And so if you want, these are the 5 challenges that we're encountering, and these challenges could lead us to a failed endodontic case, as I showed you at the beginning of this presentation. And if we go back to the basics, right? Endodontics is the control of the microbes, meaning to control really what's happening inside the root canal system by mechanically and chemically eliminating bacteria while preserving dentin. Then with all these challenges that we are facing, we are somehow failing, and we need to have a new vision, or we need to have a new concept or a new philosophy. We need what I call a paradigm shift, a complete shift in vision whereby we are going to move from a state where we are executing or doing endodontic therapy in a non-anatomical fashion, meaning not taking into consideration the intricate anatomy and the complex anatomy of the root canal system. We're going to move from that state to a state what I call an anatomical endodontic state, or anatomically centered endodontics, whereby we're going to take into consideration this beautiful anatomy and try to respect it and to clean it at the same time. And so we're going to move from a rotary instrumentation or rotary files into an instrumentation that's going to be anatomical. We're going to move away from a random irrigation, or just like irrigating these canals with various irrigation solutions, to a solution that's going to be able to meet the anatomy of the root canal system and clean it well. And we're going to move from gross obturation, or just filling, if you want, this root canal system and compacting the material in there, to an anatomical obturation, whereby we're going to seal the anatomy of the root canal system. And this is, if you want, the concept or the basis of anatomically centered endodontics, or ACE, the acronym that we use. And to start talking about anatomically centered endodontics, we're going to start to look about how we're going to be able to move from a rotary instrumentation to a anatomical instrumentation. You have here on the top left an oval canal, and when we are using, if you want, conventional techniques, we either tend to under prepare the canal. This is the gray part here, the area that has been prepared, or over prepare the canal a bit in order to include a bit of the infected root canal anatomy, but saving a bit more of the safe or the healthy dentin. But whether you're under preparing or over preparation or over preparing the root canal system, you are not respecting the anatomy of this canal. What we need is an instrument, or is it a technique or an instrument or something that will be able to span or to sweep the total area of the canal without changing its anatomy, but just respecting the anatomy and removing all the bad guys, the bacteria. This is anatomical instrumentation. And this anatomical instrumentation, this concept, this idea, has been illustrated the first time by nobody else but Herb Schilder, who in the 1970s said that it's the tooth and not the file who should determine the final taper, and then we have to have a certain file that will move down the canal like a certain snake motion in order to clean up the canal very well. Of course, in the 70s, this idea or this concept was completely, if you want, advanced. We didn't have the technology nor the knowledge on how to do it. And the focus was more on how to obturate the root canal system. So this has been forgotten. And with time, with the advancements in science of niti, of various metallurgic alloys, we're able today to, if you want, come with a material or with a file, with an instrument that's able to, if you want, move down the canal like a snake and clean the tooth and without changing the anatomy. And this is the instrument that I'm talking about. It's called the X3D Shaper Plus. This instrument has been introduced by Brasser originally in 2016. And as you can see, it has a shape of a snake, and it has an adaptive core technology that could instrument the canal in question up to a size 3004. Now, a lot of you maybe have heard me before talking about the traditional XP3D Shaper, or the first generation of XP3D Shaper, which used to have a switch in conformation of the crystalline structure of niti from 20 degrees at room temperature to 35 degrees at the tooth temperature. The reorganization of the niti structure would allow this file to go from a soft shape to a memorized shape. And this memorized shape gave the ability to the file to, if you want, expand inside the root canal and to meet the intricate anatomy and to dance with the canal, if you want, without changing the shape or the anatomy of the canal. The XP3D Shaper Plus has been designed in order to really not have to be anymore dependent on temperature change. The crystalline structure of this file is made of hyperflex alloy, and this makes it able to be in the memorized shape at all temperatures and to be able really to do the root canal treatment regardless of the temperature of the tooth. And so this file, one of the biggest advantages is that it is adaptive to the original shape of the canal. If you look at this video here, this is the buccolingual view of a mandibular incisor. We can clearly see how this snake-shaped tooth was able to, if you want, expand and meet the buccolingual direction, which we cannot appreciate on a regular X-ray, in order to really clean the canal. And if you imagine we're able to give up and down strokes motion of this file, we're able to distribute the action of this file all the way to the working gland, meaning brushing this canal, brushing the bacteria, disorganizing the biofilm, and yielding a cleaner canal in an anatomical fashion without having to drill a round hole in this non-round canal. This is the biggest advantage of this file, and it's able to fulfill this advantage thanks to its night-tie, if you want, composition that makes it able to do such a thing. Another advantage of the XP3D Shaper Plus, it's that because it has a hollow core, meaning because it doesn't have, let's say, a solid core all the way the working length of this file, we're able, if you want, to keep the debris in suspension and not to grind them and to push them and to, if you want, condense them laterally into dentinal tubules and to the lateral canals. Hence, after that, just rinsing them out with a specific solution I'm going to talk to you about in a couple of slides, and thus favoring more and more chemical, if you want, cleaning and disinfection of the root canal system. And this leads to a cleaner canal that is anatomical, of course, cleaning, and without debris left behind. If you look at this slide here, on the top part here, we have a traditional rounded files that have cleaned this root canal system. We see we have two round holes and the debris that have been accumulated in the isthmus between the two holes. On the bottom part, we have the same tooth that has been cleaned with the XP Shaper Plus. We can see how the canals are not completely round because the original anatomy, which is non-round, has been respected. And since we are not compacting the debris in the isthmus, these debris have been loose in the canal and just been flushed out in order to yield a cleaner canal with less debris, less stress, and of course, less torsional stress because we're not grinding anymore the dentin. We're not screwing anymore a screw into the dentin. We're just, if you want, brushing the dentin with this beautiful file that's able to clean anatomically. The file has also an advantage that it could be bent in order to help you place the canal in the right orifice, especially if you're dealing with a patient who has a small opening or where a tooth also has a very difficult access. This is a small advantage that helps you really reach your orifice in question. So the goal of our instrumentation technique is to be able to give a certain number of strokes for this XP Shaper Plus in order to let it react and meet all the complex anatomy of the root canal system, giving it time also in order to reach a size 30 and taper 4%, which is the why this file is designed, what is this file is designed to reach, which is a size 30 and taper 4%. And this file has to come with another file, it has to be used with another file before. That's what I call the Duo, the XP3D Shaper Plus Duo. This other file is this file here. It's a 1504 XP3D Scout. So this file is just what the name implies. It's a scout file. It's going to scout the canal in order to prepare this canal for the action of the XP3D Shaper Plus. It's a heat-treated file that gives a mechanical glide path to a size 1504, prevents the shaper from deformation, and lets it travel faster and better without any obstruction all the way to working length. And it's been used, or it should be used, at 1,000 RPM speed and 1 Newton centimeter of a torque. And these parameters are very important because these are the same parameters that we're going to be employing for the XV3D Shaper Plus. And so, for example, if you have a basic case, and a basic case is a case whereby we are just we are dealing with a simple tooth that is not calcified, there's no curves, where we could take our number 15 hand file and easily reach the working length. In this case, one can easily jump, if you want, from a 15 hand file right away to the XV Shaper 3D Plus without employing the XV 3D Scout. But I mean, these cases are very, very, if you want, less likely to be seen in a practice with, of course, everything that we see as complicated cases. We're more likely to see something like this, whereby we have a complicated case, we have calcification, we have bulky roots, we have calcified and curved canals. And we know that in these cases, you could take your number 15 hand file, put it in the orifice, and it's not going to reach the working length right away. You have to go through a number 10, 15, a number 10 hand file, make your way down the working length. And so this is the protocol. In these cases where you have a more challenging case, you're going to employ a number 10 hand file all the way to working length. After that, employ a number 1504, the XV3D Scout. And after that, employ your XV3D Shaper Plus. And in most cases, as an endodontist or as a general practitioner who sees difficult cases, we're going to be needing this protocol here. And if you want to be just have a conscious clear that the XV3D Shaper Plus is going to do its work without any obstruction or without any difficulty, then this is the protocol that you would want to use universally for all your cases when you're going to be doing a root canal treatment. Now, this is if you want the two of how to use the Scout and how to use the Shaper Plus while you're doing it clinically. When you're using the XV3D Scout, you're going to give 3 strokes to the full working length. Then you're going to irrigate and recapitulate before moving on the XV3D Shaper Plus. And the XV3D Scout is going to be used at 1000 RPM and 1 Newton centimeter as a torque. By recapitulation, I mean taking a number 10 and number 15 hand file at 0.5 or 1 millimeter more than the working length, just to try to make sure that there's no obstruction left behind and you're letting any debris being loose so that when you irrigate it out, everything comes out and nothing gets left behind, and we have less risks of obstructing the XP Shaper Plus. When you are at the stage of employing the XP 3D Shaper Plus, this has to be done in 2 stages or in 2 steps. The first step has a role of reaching the working length, meaning you're going to take the XV3D Shaper Plus and employ it 1, 2, 3 strokes until you reach your working length. Once working length is reached, you're going to irrigate and recapitulate and then move to stage 2. Now, in certain cases, even after giving 3 strokes, sometimes the Shaper Plus does not reach working length. That's fine. You will irrigate, recapitulate, and redo stage 1, and at this point, you will get to working length. And these cases, we meet them especially when you have a curved case or a very calcified case. It might require you 2 times stage 1 in order to reach working length. Once working length is reached, you irrigate, you recapitulate, and then you're going to take 8 additional strokes down the working length with the XV3D Shaper Plus in order to confer the canal a size 30 and a taper 4%. And of course, it's going to be used at 1000 RPM and 1 Newton centimeter, the same settings as the XV3D Scout. Hence, you don't have to worry about changing the speed or the torque. You're going to streamline everything. It's going to be an easy start to the easy finishes. You just set your settings to be the same for these 2 files. And this makes your life and the life of your assistant much, much, much easier. Now, some of you might be wondering, well, if this file is taking the canal to a size 3004, is it causing a lot of stress and a lot of strain on the canal? And do we have any risks of fracturing this file, or even a lot of stress on the canal that can really translate into a cracked tooth. And we can see in these, if you want, studies that have been done, that with conventional rotary file going around the curve, we have a lot of pressure points, as we see here, those brown or orange points that are appearing. But with the XP Shaper Plus, because the file doesn't bind completely in the canal and doesn't grind the canal, the file free flows along the root canal working length, and thus we don't have a lot of stress or strain, making it a very safe file in terms of file separation and micro cracks that are caused on the root. If you're looking at it from let's say on an extracted tooth, this is if you want a distal canal of a mandibular molar. A traditional round file is going to take the path of least resistance, as we see here, and this is going to translate into something that looks like this on this 3D printed tooth. We have part of the canal that has been cleaned, as we can see illustrated by the green dots, and the other part that has not been cleaned, where we still see the red material present. And this red material can translate to about 50, 60, or sometimes 80% of the untouched root canal surface, as we saw in the study earlier. Thanks to the adaptive technology of the XU3D Shaper Plus, the action of this Shaper Plus is going to spread all along the working length and the anatomy of this oval non-round canal, yielding a cleaner canal that has its anatomy respected. And most of all, we did not cause a lot of stress and a lot of strain on the canal. So we have a cleaner canal that has been respected in terms of anatomy, and also a more rigid canal than a round file treated canal, because we didn't have to remove excessive dentin in order to reach our microbial control. And so this is a new thing, if you want, a new concept whereby it's not the file that's giving the shape to the canal. We're not shaping the canal anymore, we're just cleaning it. So it's the canal really that's giving the shape to the file. And this is what Herb Schindler said in the 70s. It's the canal that's going to determine how the file is going to act inside of it in other way. And this is what we mean by a shift in paradigm. We're going to change our vision of shaping the canal. We're going to change our concept of just taking a file and doing a round hole inside the canal. We're going to now adapt in an anatomical fashion of cleaning the canal, thanks to this file here, which we have now, which is the XP3D Shaper Plus. And this really reminds me, if you want, about of a certain procedure that are done in cardiac surgery. And funny enough, cardiac surgeons use stents that are made of nitinol, which is a very similar alloy that is used today in the XP Shaper Plus, whereby they put the stent in an obstructed artery, and they want that stent to inflate and to meet again, if you want, the elastic resistance of that artery. It's the same concept with this file. It's meeting, if you want, the outside or the anatomy of this root canal system in order to clean it without overinflating this root canal system, just like the stent doesn't overinflate the artery, in order to avoid, if you want, rupturing the artery, and in order for us to avoid removing excessive dentin. So this really is the beauty of this file. And again, the biggest advantage is that it's adaptive to the original canal shape. And this is, if you want, going from a rotary instrumentation to an anatomical instrumentation, whereby we're really treating the anatomy of the canal. Studies have shown that this file is advantages in multiple aspects: superior flexibility, centering ability, respect of the anatomy, bacterial reduction, and debris accumulation, less debris accumulation and compaction, making it really a superior file that can really help us reach microbial control in an anatomical fashion. So now that we've looked on how to switch from a rotary instrumentation to an anatomical instrumentation, we still have to deal with the biofilm and how bacteria travel all the way to the dentinal tubules. And this is what I like to call deep disinfection. So after instrumenting the canal, we need to go deeper now and disinfect and to scrub the areas where the biofilm are, and somehow try to send a bit of irrigating fluids into the dentinal tubules to control those microbes that have traveled down the dentinal tubules. And so we need something that's able to scrape the biofilm, because biofilm is very hard. Just like if you want the periodontal biofilm, it doesn't get removed just by flushing. We need to scrub it, we need to scrape it, or we need to brush it. And we need to do that with something that avoids blocking the unreachable areas, meaning we need to scrape this biofilm, but not to leave it behind. We need to like put it into suspension in the canal and irrigate it out, while avoiding the weakening of the tooth or removing unnecessary dentin, and having a solution that can flush this out and neutralize what's left behind. And to do this, we need a new file that is, if you want, the cousin of the XP3D Shaper Plus, which is the XP3D Finisher. And the XP3D Finisher comes into two sizes. That's why you have one that has the red band here and one that has the blue band here. The red band is has the tip size of a size 25, and the blue band has a tip size of a 30. So the tip here is equivalent to a size 25 file, and the tip on the blue band is equivalent to a size 30. And the most important thing to remember is that this file has no taper. It's a straight wire. And when you don't have any taper, it means that you are not cutting dentin. You're not removing dentin. You're not, if you want, removing any dentinal structure, any tooth structure. You're just going, in other words, to rub against the root canal wall in order to remove whatever is there. And this file is made with max wire, which is the same alloy that the original XP3D Shaper was made of. And it changes conformation from the room temperature here, which is in the M phase, to the A phase when it's inside the tooth at tooth temperature. And so after a certain time and giving long strokes inside the canal, we're able to take this A-phased XP3D finisher all the way to working length, spreading its brushing and its scrubbing action in order to remove what's left behind, namely biofilm, and in retreatments, as I will show you in a couple of slides, any gutta-percha or sealer left behind inside the root canal system. If you look at this series of pictures that you have in front of you here, we can see that in a buccolingual direction, this central incisor here, when you take a round file, really has a lot of areas that's been untouched. If you see on the next four pictures, we see how the action of the shape of the finisher happens when you have scrubbing with the tip of the file or just rubbing with the body of the file against the root canal wall. So we are spreading the action of the tip of the file and of the body of the file all along the working length against the various aspects of the root canal anatomy in order to remove what's left behind. And so you can imagine this finisher being inside the canal. When it's squeezed at its body, it's the tip of the file here that's going to act as a whip or as a helicopter, if you want, that I would like to call, and it will shave around it any debris, any biofilm left behind. Conversely, and as you will see in the video, if it's the tip of the file that's going through a very narrow part of the root canal area, this is where we're going to have the ballooning or the expanding part of the file, while the body of the file will rub against the root canal anatomy and scrub and remove the biofilm or any gutta-percha tags left behind. And this file is, again, a straight file. It has no taper, so it will not increase your final apical size. It will just remove the debris and give you a cleaner canal. This file is to be used after conventional instrumentation. If you still have some file in there and you want to have a better microbial control, it's a good idea to throw this file inside after the XP3D Shaper Plus in order to reach all the areas that have biofilm. As you can see, this is the action of the file inside the tooth. In an oval canal, you can clearly see and appreciate how it's going to really go back and forth in a buccolingual direction, and it's going to agitate this fluid inside the tooth. That's going to really send this fluid in the dentinal tubules in order to really favor better cleaning and disinfection against the bacteria that travel down the dentinal tubules. When you have retreatment cases, this is a file that's very necessary and very important in order to remove any gutta-percha left behind. And when you have large canals, such as immature teeth or dense dentes, or what I call special anatomy, this file is going to be able to marry itself and to dance with this variable anatomy and yield a cleaner canal. So these are, if you want, the indications for the XP3D finisher here. We use it with Triton, which I'm going to be talking about this irrigation solution in a bit, at 1,000 RPM, 1 Newton centimeter, giving a full length amplitude 5 to 7 millimeter for 60 seconds or for 1 minute inside the canals, and it could be used up to 6 canals. Now, the exfiltrative finisher has been shown to act like a whip as a brush to destroy biofilm, dislodge gutta percha, create turbulence in an anatomical fashion. So it's helping us to reach our microbial control in an anatomical way, respecting the original anatomy of the root canal system. And this is another video showing you the range of motion of this beautiful file. We can clearly see how it can really spread and really encompass or englobe a very large range of motion in order to meet the irregular anatomy of the root canal system that we are dealing with. And so it's acting as a scraper or as a periodontal curette. This is how I would like to think about it. It's going to really scrape all the biofilm inside the root canal system. Now, this is anatomical instrumentation, and now we're going to talk about anatomical irrigation. In terms of irrigation, it's very simple. Most of us here have been using sodium hypochlorite at various concentration with one thing in mind, meaning that increasing concentration increases the solvent action of sodium hypochlorite. However, studies have shown that sodium hypochlorite can be buffered or neutralized by various debris inside the root canal system. Hence, this is why we've been always told to increase the volume or to refresh or to renew the volume of sodium hypochlorite inside the root canal system. This is why we've been also told to use multiple solutions or multiple also, if you want, agitating techniques in order to favor really the disinfecting action of sodium hypochlorite and other solutions. To really simplify irrigation and to make us, if you want, less spending time looking for this solution and employing this activating gadget or instrument during root canal treatment, Brasser came with a new irrigating solution called Triton, which is a 2-in-1 irrigating solution where you have one compartment that has 8% sodium hypochlorite and one compartment that has a mixture of, if you want, chelators and surfactants. And it comes with a lower lock here where you could put your syringe in there and just suction up that solution. The solution gets mixed up automatically with the right ratios to give you a solution that's able to clean well and disinfect well your root canal system. And so it's one solution rather than having 3 solutions. And it has been shown that it could really dissolve organic matter almost twice as fast as regular sodium hypochlorite. It has a long-term better stability than sodium hypochlorite alone. And new research published very recently in 2024, this is a master's thesis by Dr. Al-Balushi from the University of British Columbia in Canada, where she found that Triton has shown to have a superior antimicrobial effect when it's used against biofilms that are 3 weeks old. It's a new solution, so studies have slowly starting to appear on there. Of course, we have to keep an open eye on more studies coming up, but at least we have a promising irrigating solution that really solves having multiple solutions and multiple activating instruments that will help us streamline the procedure of endodontics and make it easier for us and for our assistant in order to really make the treatment flow faster. And most importantly, of course, having a good antimicrobial anatomical effect, because this solution is going to really flow down thanks to its surfactants and chelators all the way to the cleaned root canal surface area that has been cleaned, of course, using anatomical instruments such as the X3D Shaper Plus and the X3D Finisher. Retreatments have been also, if you want, a target of anatomically centered endodontics. And in terms of retreatments, the biggest challenge for us is to deobturate the root canal system. And so we spend a lot of time doing that. And today, thanks to the shape, thanks to these 2 new materials here, these new instruments, we're able to do anatomical retreatments. We're able to use the shaper that has a wine opener shape in order to remove the gutta percha, and whatever tags are left behind, we're able to scrape them and to remove them thanks to the action of the finisher. So this is the protocol that we recommend for the retreatment of cases. The first step is to deobturate, and then we're going to regain microbial control. But all that is done in an anatomical fashion, keeping in mind respecting the anatomy of the root canal system. And this has been shown really using the shaper and the finisher to do retreatments twice as faster and to have cleaner canals once we have removed the old root canal filling. And so this XP family, if you want, this new generation of instruments is, if you want, an evolution of biochemical instrumentation where we have the same goals, which is to clean the inside of the root canal system, but having different approaches. Same thing for our anatomical instrumentation. We have the same goal, which is chemically disinfect, but we're using a different approach, if you want, a more effective, a more efficient solution, which is triad. And now finally, I'm going to spend the last 15 minutes talking about the paradigm shift in obturation, which I'm sure a lot of you here are already familiar with it. The problems of obturation, I've already listed it for you, which is the shrinking of the sealer, the washing away of the sealer, the lack of interaction of the chemical bond between the sealer and the dentin, between the dentin and the gutta-percha, and everything leading eventually to microbial leakage. This is, if you want, what we are dealing with traditional sealers. We don't have any communication or any bond between the gutta-percha and the sealer, or with the sealer and the dentin. So we need to move from that state to somewhere where we have really a communication, or if you want, bonding inside the root canal system. And this will be able to reach this goal thanks to bioceramics, which are ceramics that have been highly purified and that can be used in order to repair and reconstruct damaged tissue. In our case, the damaged tissue, when you're doing root canal treatment or endodontic therapy, is the periapical tissues. Bioceramics have been used in various medical fields, and now we're employing it more and more into dentistry. The biggest advantage of bioceramics is that when they set, they produce calcium hydroxide and they produce hydroxyapatite. And we all know that calcium hydroxide is an antimicrobial agent, and hydroxyapatite is a biocompatible, bioactive, and dimensionally stable material. So if we can combine these qualities into a sealer, we can really overcome all the challenges that we are facing, or all the shortcomings we are facing when we are dealing with the obturation of the root canal system. And bioceramics have been also proven over time and time through various studies to be hydrophilic, to be stable dimensionally, to be insoluble, to have an alkaline pH, to be bioactive, to be biocompatible. So they offer us a wide range of, if you want, biological advantages. And if you're looking for a perfect sealer in endodontics, you want a sealer that has all these advantages here, because it will help us to overcome everything or every challenge that we encounter with root canal obturation. Bioceramic sealers in endodontics today are taking a huge expansion. Every, if you want, a company is trying to create its bioceramic sealer. The most traditional one, and the one that, if you want, that has set that race in bioceramic sealer to now be initiated, is the EndoSequence species sealer, which has been introduced, I believe, in around 2009, 2010. And this is the sealer that has been studied and investigated a lot. And today is used, if you want, as the comparison when we're trying to, when we're trying to, let's say, compare a new bioceramic sealer that has been introduced into the market, because it has proven itself to be really reliable in terms of sealing the root canal system. In order to employ the sealer clinically, what has to be done is, after finishing your instrumentation protocol, you select your gutta-percha cone and you adapt it, as we see on this first picture here on the left-hand side. The bioceramic sealer has a very big advantage, is that it's made of very small particles and it's injectable. So you inject a small aliquot or a small volume of sealer inside the root canal system. I usually tend to introduce my syringe almost halfway of the canal and inject while retrieving my hand. You can then, if you want, and this is an optional step, to use the lentulus spiral in order to shake down or to spread down the sealer all the way to working length. And then you could really place your gutta-percha cone all the way to working length, and the hydraulic force of the gutta-percha as it's placed inside the canal will create enough pressure to spread that sealer everywhere, and to really make sure that the sealer has been, if you want, seated all the way to working length. And then all you have to do is to cut that gutta-percha at the orifice level compact a bit the orifice to make sure that your gutta-percha is flat, and your job is done. And this is it for that sealer. The beauty of it is that you don't have to condense, you don't have to heat, because the sealer is very performing, because the sealer doesn't retract, because the sealer doesn't wash away. It's a sealer-based obturation technique. So we want to really make sure that the sealer is there, and all you have to do is to place it in the canal and make sure it's spread everywhere, thanks to the hydraulic condensation with the gutta-percha. When using the XP 3D Shaper Plus, at the beginning, you're going to maybe have a bit of a challenge in order to really know how much time to give during your 8 strokes. So you might finish somewhere in between 25 or 35 as a final apical size. And so to avoid the guesswork while choosing your gutta-percha cone, you could use apical verifiers, which are these non-cutting NiTi hand files that you could put inside your canal, hook it to your working length, and you see which one is adapted the most into the shape of your root canal system, and then use that size in order to choose your adapted main gutta-percha cone. It's a step that might be needed at the beginning, but the more you become familiar with the XP 3D Shaper Plus, you'll be phasing out that step very, very, very fast. And so we're going to be moving from that state, a gross obturation technique, just putting material inside the root canal system, into a state where we have an interaction between the dentin and the sealer and the gutta-percha, eventually creating a bonded obturation inside the root canal system. And that bonded obturation is going to flow inside this beautiful anatomy that you have just cleaned with the XP 3D Shaper Plus. Because the bioceramic sealer is very flowable, is made of very small particles that lets it really hug, if you want, all the interior of the root canal system. And so the shift now, we are shifting from using gutta-percha as a main, if you want, agent to condense and to compact in order to compensate for the sealer that's going to retract and to wash away. We're going to be using it in order to create enough hydraulic pressure to spread the bioceramic sealer everywhere. And this technique has been shown that it has increased resistance to fractures in teeth, and it doesn't lead to micro cracks. And all we need to do actually, and because it needs a conservative instrumentation, since you're not using any heated plugger all the way to 3 or 4 millimeter of the apical part, it yields a conservative instrumentation, less micro cracks, and increased resistance fracture. And should you have a sealer extrusion, unlike traditional sealers that are cytotoxic, endosequence bioceramic sealer has been shown that if or should you have an extrusion for whatever reason, you shouldn't worry about it. It will have actually a good effect on the recruitment of osteoblasts and bone in the area because of its biocompatibility and non-cytotoxic advantage that we have with endosequence BC sealer. So endosequence BC sealer, as I said, can flow everywhere. On the right-hand side here, you have the BC sealer, which is in white, traveling or hugging or occupying all the space of the root canal anatomy with the gutta-percha cone in there just to act as a plugger or as a spreader to condense the sealer everywhere. On the left-hand side, you have a traditional sealer that has been used, that has washed away, giving rise to microbial leakage. This is this black line, if you want, around the gutta-percha cone. And this gutta-percha cone is just, if you want, floating inside the root canal system without any role. It's not sealing, it's not in interaction with anything, it's just there doing nothing. And this is what's happening with a lot of our traditional sealers, is that we're losing the sealing of the tooth, and thus we are contributing somehow, the tooth is becoming prone to microbial leakage. And this is something that is easily avoidable thanks to the new techniques of anatomical obturation using BC sealer, and thanks to the advancements in technology and in bioceramics. So in order to conclude our webinar today, this is where we are heading today in the discipline of endodontics. We're moving into a state where I would like to call it conformity in instrumentation. We are conforming our files to the anatomy of the root canal system in order to give an anatomical preparation in a conservative, secure, and efficient manner. We are also conforming our irrigation techniques to the anatomy of the root canal system using less armamentarium, less material, making it faster, easier with one solution that cleans, disinfects in an efficient manner. And we are also getting conformity, or we're getting into adapting our instrumentation techniques, our obturation techniques, to the root canal system anatomy, thanks to the advancement of technology in bioceramic sealer, where we have a sealer that is a main player that really can be flown, that be injected into the root canal system in an efficient manner, and is a biocompatible material that will not shrink and have dimensional stability. And so this is what I call anatomically centered endodontics. This is the new state that we have to have in mind. This is the new concept that we have to favor in our clinic. Anatomically centered endodontics is today something that is possible thanks to the advancements of modern materials and methods with bioceramic sealer, XP3D Shaper Plus, XP3D Finisher, and Triton. And this streamlines endodontic treatment. We're treating the anatomy from start to finish, and this eventually has the potential to improve the success rate of our endodontic therapy. And of course, with time, I'm sure we're going to have studies that will appear telling us that this is how really endodontic treatment is proceeding, having better and better success rate and streamlining our procedure in a fast and efficient and certainly safe method. With that, I would like to thank our two sponsors today, Brasseler and Endodontic Practice. Thank you for having me. Thank you also for everybody who listened to me for this past hour. I would like also to say thank you for the Penn Endo faculty that gave me the training in endodontic that I received while I was a resident. And if you have any question or anything that you would like to add to my presentation, this is my email here on the bottom. I would like to thank you all once again, and looking forward to seeing you in person in other meetings. Thank you.
Thank you so much, Dr. Safi. That was a really great presentation. There are some questions coming in, but before I get to those, I'd like to again invite viewers to use the question and answer feature in the control panel on your screen to ask any questions. First question, are there any cost considerations to adopting the anatomically centered endodontics approach?
Well, in terms of anatomically centered endodontics, you need, of course, to have a handpiece and a rotary engine that's able to give you a certain minimum speed and minimum torque, which is 1,000 RPM and 1 Newton centimeter of a torque. So if you don't have that in your clinic today, you might want to invest in one of these engines. But in the other part, just with the shaper and the finisher, Triton, and the bioceramic sealer, you're eliminating a lot of extra accessory instruments, or what I like to call accessory gadgets in your clinic that you don't need anymore. So that you're actually saving quite substantial amount of money if you adapt to the anatomically centered endodontics concept.
Okay, next question. Can this approach be incorporated in phases, or is it best to do it all at once?
I recommend doing it personally all at once, because if you want to treat the anatomy, you have to adapt the anatomical instrumentation, the anatomical irrigation, and the anatomical obturation. I wouldn't tell you to start with the instrumentation and then move to the irrigation and then move to the obturation. It's a concept, it's a philosophy that has to be taken as a whole. What I would suggest you do, however, is to start with simple cases and then increase the complexity of the case the more that you become familiar with the instrumentation, with the feeling of the file, and with how to employ all these instruments inside the root canal system.
Okay, what training or learning curve should I expect when incorporating anatomically centered endodontics?
So this is what I mentioned right before in the previous question. I suggest that you start with the simple cases, let's say central incisor or like basic cases, so that you have a feel of how the file is employed, what is the feeling with the handpiece, how would you use the bioceramic sealer. So there is a bit of a learning curve that has to be done. I would say maybe depending also on the frequency of your endodontic treatment that you do in clinic, After, I would say, maybe 10 or 15 basic cases, you're able then to move to more and more complicated cases.
Are there any specific cases where the anatomically centered endodontics approach might not be recommended?
No, it's a universal approach. It's a universal protocol that could be used in order in all situations and all scenarios.
Can the ACE irrigation solution be used in conjunction with ultrasonic irrigation devices?
So Triton can be used with ultrasonic irrigation devices, but you don't need to. You don't need to, because if you're adopting the anatomical centered endodontics and you're employing the shaper has been shown to be superior to any ultrasonic irrigation that you might use. And the Triton is very performing in the sense that it will spread all the way inside the canal thanks to its chelators and surfactants, and yield a cleaner canal without having the need to do any ultrasonic agitation.
Can anatomically centered endodontics be applied to retreatment cases? And if so, how does it affect the approach?
So if I understand well, the question is, can we use ACE in retreatment? And yes, of course you can. ACE in retreatments is a protocol that I shared before in the slide, where you have the first step, which is the de-obturation, and the second step, which is the regaining of the microbial control anatomically. If you do a retreatment using the ACE techniques, you're able to get a faster, cleaner canal with less gutta percha and less material inside, and it just makes your treatment much, much, much faster. And certainly, personally, I find it much funner because you're able to really clean faster, and you see that gutta percha being pulled out with their shaper, just like some kind of like pasta or something being pulled out from the canal and really yielding a cleaner canal.
Okay, are the XP3D Plus files, specialized irrigation solution, and bioceramic materials available in North America only or worldwide?
I believe that the XP3D Shaper Plus, the XP3D Finisher, and the EndoSequence Bioceramic Sealer are available worldwide. The only thing that I think is only available in North America, meaning in the United States and in Canada, is the Triton irrigation solution. I don't think that it has been launched outside of North America.
Okay, and our last question. While you mentioned the long-term success of ACE, are there any ongoing studies or data that can provide more specific information on their durability and clinical performance over more than 10 years?
So I mean, this concept is relatively new. It's about maybe a year or maybe 2 years old. Putting together anatomical instrumentation, anatomical irrigation, and anatomical obturation. So we don't have 10 years of practice yet with it. So I'm not aware of any study that has been done. It's a very new concept. So I would say maybe in 5 years or so, we might start to see more and more studies coming out that really evaluate the effect of that trio, the triad, instrumentation, irrigation, and obturation, but that has been executed in an anatomical fashion using these instruments that I showed you. Maybe in 5 years or so, we might see a couple of studies that will be published.
Okay, great. Well, thank you everyone for your questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, all registrants will be emailed a link to the replay and a continuing education quiz to complete for the certificate. Thank you all again for attending, and a very special thank you to Dr. Chafic Safi and our sponsor for this webinar, Brasseler USA. Thank you, and stay safe out there.
Thank you very much.